Assalamu alaikum warahmatullahi wabarakatuh. How are you, my dear? I will discuss with you, inshallah, today oxygen therapy. As we know, there are multiple devices to deliver oxygen to the patient. Oxygen is a drug, like any medication you prescribe to the patient. Devices to give oxygen to the drug divided into two main categories: fixed performance and variable performance. What we mean by fixed performance, give fixed oxygen supply to the patient. Whatever the patient has tachypnea or increased respiratory rate or lower than respiratory rate, it will give a fixed oxygen tension to the patient, regardless of the patient respiratory rate. And we have variable performance. If the patient increases respiratory rate, it decreases oxygen supply. If the patient decreases respiratory rate, it will increase the oxygen supply. So variable performance devices, there are different types of variable performance devices, either low or high flow of oxygen, which are nasal cannula, simple face mask, non-replacing mask, and replacing mask. But we have four variable performance oxygen devices, either low or high, give variable oxygen concentration to the patient, which are nasal cannula, face mask, non-replacing mask, or replacing mask. In nasal cannula usually give من 1 to 6 or يعني by approximation من 1 to 5. يبقى nasal cannula give concentration. يبقى I must open the flow of oxygen if the patient is taking nasal cannula to adjust the flow of oxygen from 1 to 6 liter. More than 6 liter, it will be wasted. Less than 1, it will not be beneficial to the patient. Oxygen mask from 5 to 8. From 5 to 8. So I adjust the oxygen flow from 5 to 8. Mask with reservoir, replacing mask from 6 to 10. Replacing mask from 4 to 10. Nasal cannula may give up to from 25% to 45% to 44%. In oxygen mask give from 40% to 60%. In mask with reservoir give from 60% to more than 99%. In non-replacing mask give from 60% to 100%. So if we see mask with reservoir bag, high flow, non-replacing high flow, while nasal cannula and oxygen mask low flow. This is the nasal cannula. The nasal cannula can deliver flow from 24% to 45%. Will flow, I adjust the flow from 1 to 6. Will maximum flow rate is 6. Advantage, it is inexpensive, well tolerated to the patient because the patient can speak, can eat, can drink, maybe mostly humidified. Disadvantage may cause nasal irritation or irritation of the nasal mucosa. As regard the face mask, oxygen flow from 5 to 10 liter per minute. Advantage, it is lightweighted delivery, may reach up to 60%. So if I need more oxygen than to the patient, I use a face mask, not a nasal cannula. A disadvantage, the limitation of access of the patient to the face. يعني the patient is not comfortable with the face mask like a nasal cannula. The patient may get vomited into the mask and he may re-aspirate his secretions. Uncomfortable, especially if there is facial trauma or burn to the patient, cause dryness and irritation of the eyes. The partial breathing mask, the design of the partial breathing mask similar to that of the simple face mask with the addition of oxygen reservoir pack. Only it is the same as simple face mask but added oxygen reservoir pack. Allow delivery of IO2 greater than 60%. This oxygen reservoir bag is filled with oxygen, so it gives high flow of oxygen. Exhaled oxygen from the anatomic dead space is conserved. It disadvantages and mask prevent access to the mouth, the same as the face mask. The flow rate of 15 liters per minute may be insufficient to severely dyspneic patient. So we come to Venturi mask. Venturi mask gives fixed performance, and it has multiple added colors like red or yellow or green or blue, and each color has a specific oxygen saturation, oxygen flow. This is the Venturi mask. It gives the flow, if I to deliver the ranges from 25% to 60%, or will flow ranges from 4 to 12 liters per minute. The advantage delivery of IO2, which can be adjusted as needed, useful in patient on home delivery of excessive oxygen, good depress the respiratory center. As we said, it is fixed performance. Fixed performance. If we return to before previous slide. Nasal cannula, face mask, non-repressing and repressing mask, these are variable performance. While fixed performance is the Venturi mask. It gives fixed flow, whatever the respiratory rate, whatever the condition of the patient. Okay, so it is useful to adjust the flow in hypercapnic patients, especially in hypercapnic patients. Useful in tachypnic patient, useful in hypercapnic patient. If you want to give specific oxygen supply to the patient. In manual resuscitation bag, useful to provide oxygen and positive pressure ventilation to seal the airway, such as mask, endotracheal intubation, and tracheostomy, and we use it only on comatose patient. This is manual resuscitation bag. Before giving oxygen, you should ask yourself 3 B's. What are the purpose of giving oxygen? Who is the patient I'm dealing with? Which performance I need? These are used in the initial selection or recommendation of a change in oxygen delivery. The goal is to match the performance of characteristic of equipment to both the objective of therapy and the patient's specific need. Patient factors in selecting oxygen therapy: severity and the causes of hypoxemia. Is the patient severely hypoxemic? And what is the cause of hypoxemia? It is acute onset or chronic hypoxemia. Patient age group and cooperation. If the patient cooperative, I can use the face mask. If the patient is uncooperative, it is better to use the nasal cannula. Degree of consciousness and alertness. Presence or absence of tracheal airway stability, tracheal airway injury, stability of minute ventilation, which is very important. Stability of minute ventilation, which is very important, especially in hypercapnic patient. Here, minute ventilation is unstable, so it is more better to use Venturi mask. Mouth breathing versus nose breathing patient. For example, a simple face mask at 5 to 6 liters per minute is probably more suitable than a nasal cannula at 4 liters per minute for a mouth breathing patient, mildly hypoxemic patient. If the patient is not critically ill and there is no risk of hypercapnia, as in cases of acute asthma, severe pneumonia, and pulmonary fibrosis, the initial target SpO2 will be from 94 to 98%. The initial oxygen therapy is nasal cannula or simple face mask unless started otherwise. For patients who have saturation below 95%, treatment should be started with a reservoir mask until oximetry or blood gases become stable. I hope you understand, my dear. For there is risk of hypercapnia as in cases of moderate to severe COPD or scoliosis or kyphoscoliosis or neuromuscular disorders. The initial target oxygen SpO2 will be 88% to 92%. The initial oxygen therapy is Venturi mask or nasal cannula, but adjusted to 49% to 48% if PaCO2 is normal, unless there is a history of previous hypercapnic respiratory failure requiring mechanical ventilation. Lastly, you should document oxygen therapy in the patient file. What are the complications? The most common complication: oxygen toxicity, depression of ventilation, retinopathy, absorption atelectasis, fire hazards. Non-invasive mechanical ventilation. When we are talking about non-invasive mechanical ventilation, it refers to technique of augmenting alveolar ventilation without endotracheal intubation. It is the same idea of mechanical ventilation, but without endotracheal intubation. Why endotracheal intubation is hazard? There is multiple complication of endotracheal intubation. To the mouth, it leads to lip ulceration, broken or dislocation of tooth. In the larynx, it may go to glottic edema, laryngospasm during intubation, vocal cord dysfunction with stridor, inability to verbalize, trachea, tracheomalacia, tracheal edema, and necrosis, tracheoesophageal fistula, tracheoarterial fistula, tracheal narrowing from granuloma, Bronchial tree may reduce mucociliary clearance, impaired coughing, aspiration, increase the risk of nosocomial pneumonia, multiple risks for complication of endotracheal intubation. So if you have the choice to start with non-invasive mechanical ventilation, start with it first. Non-invasive ventilation, there are two parts. I have the ventilator or the device, and I have the interface. The device may be a portable non-invasive ventilator, which is very simple and very comfortable, or ICU ventilator using a non-invasive mode. Easy to trigger, adjust to leaks, deliver large volume, variability of mode, single mode of ventilator. It is very simple, very easy to be applied to the patient. And how I will apply it to the patient, I use specific masks, not the ordinary face mask or nasal cannula. I need specific masks for non-invasive ventilation, which are full face mask, oronasal mask, or mouthpiece mask, or oral interface. In portable ventilator, there are two modes in portable ventilator. I may use CPAP, which is continuous positive airway pressure, or BiPAP, IPAP, or EPAP, in inspiratory positive airway pressure and expiratory positive airway pressure. I use either this or this. These are the types of interface. This is the oronasal mask, nasal mask. We have a mouth here is opened. We have nasal pillows. How non-invasive ventilation is acting? There are two hypotheses: rest hypothesis and resetting hypothesis, and increase the lung compliance. Rest hypothesis meaning resting the respiratory muscles, leading to reduction in breathing workloads, leading to improvement in arterial blood gas. Resting the lung muscles, making the lung taking the upper hand in function and leading the rest of the respiratory muscle. Resetting hypothesis, resetting of the respiratory center sensitivity to CO2, so it will lead to improvement in respiratory function. And lastly, increasing lung compliance. The goal of non-invasive ventilation: short term, long term. Short term, relieve symptoms, reduce work of breathing, improve or stabilize the gas exchange, optimize the patient comfort, good patient ventilator synchrony, avoid intubation. We have long term, improve sleep, maximize quality of life, enhance functional status. Which patient I use non-invasive mechanical ventilation? In case of acute respiratory failure, hypercapnic respiratory failure or hypoxemic respiratory failure. Hypercapnic as in COPD, bronchial asthma, sleep apnea, restrictive lung disease, cystic fibrosis, lung transplantation. Hypoxic cardiogenic pulmonary edema, ARDS, severe capital excess, post-operative respiratory failure, and trauma. I may use non-invasive ventilation other conditions like post-extubation respiratory failure, weaning modality, difficult weaning, advanced diseases, immunocompromised patient, pediatric complication. In case of chronic respiratory failure, I use it in restrictive lung disease, obstructive lung disease, central hypoventilation, obstructive sleep apnea, and sometimes in pediatric use. I must select the patient who is capable of using non-invasive or I must select the patient who is fitted for non-invasive mechanical ventilation. So I have patient selected criteria. Respiratory failure without the need for immediate endotracheal intubation. Suppose my patient coming to me with cardiopulmonary arrest, so no time for non-invasive mechanical ventilation. At this time, I must do endotracheal intubation and make mechanical ventilation for my patient. The patient must be cooperative. How to use the interface, how to use the mask to prevent a leak. Hemodynamic stability. My patient must be hemodynamically stable. If the patient is hemodynamically unstable, it is contraindicated for non-invasive mechanical ventilation. No active cardiac arrhythmia or ischemia. No active upper GIT bleeding. No excessive secretions. Intact upper airway function. No acute facial trauma. Proper mask fitted achievement. Exclusion criteria: any patient with apnea, any patient with hemodynamic or cardiac instability, uncooperative behavior of the patient, facial trauma, high risk of aspiration, copious secretion, any anatomical abnormalities. And I should make proper selection for interface. Acute setting, I use oronasal mask. Chronic setting, either nasal or nasal mask or nasal pillows or mouthpiece, because it will be lifelong for the patient. And the patient must have cooperation with using the CPAP and the mask, patient encouragement and education, proper sizing and fitting of the mask, proper feeding and speech to the patient. I have to monitor non-invasive ventilation. We have subjective response, we have objective response, and we have gas exchange abnormality. Subjective response from the patient. Ask the patient, are you comfortable? Your DC is decreased. What you see, mental status of the patient, fatigue, hypersomnolence. Objective response, heart rate, respiratory rate, sternomastoid activity, air leaking, tidal volume, gas exchange, oximetry, and arterial blood gas. Outcome predictors, my patient must be cooperative. There is intact neurological function, intact dentition, able to control secretions, able to coordinate breathing, ventilator, minimal air leak, low severity of illness, respiratory acidosis, improvement in gas exchange, improvement in respiratory rate and heart rate. Weaning from non-invasive mechanical ventilation. I can't stop non-invasive mechanical ventilation immediately. I should do weaning for the patient. We have clinical stability criteria, respiratory rate less than 24 per minute, heart rate less than 110, pH less more than 7.35, oxygen saturation more than 90%, techniques of weaning, decrease the period of non-invasive ventilation or level of pressure support, use of oxygen nasal cannula, successive outcome denoting by improvement of clinical parameters, improvement of gas exchange, discharge from hospital, avoid endotracheal intubation. Weaning failure, meaning my patient will need endotracheal intubation. Criteria include inability to tolerate the mask, failure to improve mental status within half an hour, inability to improve gas exchange or dyspnea, excessive secretion, hemodynamic instability, ECG instability like ischemia or arrhythmia. And these are the complications of H1. Advantage of non-invasive ventilation is no endotracheal intubation, easy to administer, leading to early intervention, easy to discontinue, early weaning, cost effectiveness, decrease the duration of mechanical ventilation, decrease the length of hospitalization, decrease hospitalization morbidity and mortality, decrease the diagnostic and therapeutic cost. Now we come to principles of mechanical ventilation. What are the goals of mechanical ventilation? Improve ventilation, improve oxygenation, improve lung mechanics, maintain patient comfort while preventing complications. Mechanical ventilators provide supportive therapy. The ventilator is not a cure for any disorder, rather it allows support of breathing while disease processes are treated. We have total mechanical ventilation and we have partial mechanical ventilation. In total mechanical ventilation, the machine completely provides breathing. The patient don't share. Used when respiratory muscles are exhausted and or severe respiratory failure. We give complete paralysis of the patient, complete sedation, the muscle relaxant for the patient. No share from the patient at all. The machine takes the upper hand all the process. In partial mechanical ventilation, the machine partially provides breathing. The patient share used in less severe respiratory failure and or during recovery or weaning phase. In ventilator, in invasive mechanical ventilation, I must put the or monitor the ventilatory setting, which are ventilatory mode, respiratory rate, tidal volume or pressure setting, inspiratory flow, IE ratio, inspiration-expiration ratio, beep FiO2, and inspiratory trigger. I should adjust all these parameters. These are the phase variables, which as trigger variable begin with inspiration like pressure with time will flow. There is limit variable limiting the inspiration, target can't be exceeded, the pressure will volume will flow. Cycle variable end the inspiration, ending the cycle of breathing, the pressure cycled, volume time cycles will flow cycled. Expiratory and inspiratory change over the trigger variable. The variable that determines the initiation of breath is known as the trigger variable. Inspiration may be initiated by the patient or by the ventilator. By the patient in partial mechanical ventilation. By the ventilator in total mechanical ventilation. When the patient spontaneous respiratory effort initiates the breath, the ventilator must be able to sense the patient's effort and begin inspiration. The trigger may be flow or pressure or volume. When time triggering, the ventilator initiates the breath at a preset time interval, and the time interval is determined by the respiratory frequency, اللي هو I ratio. Inspiratory phase. During the inspiratory phase, positive pressure is generated to create a positive gradient, a pressure gradient that leads to lung inflation. Limit variable, the parameter can reach and maintain a preset target like pressure or volume or flow before inspiration ends but doesn't terminate inspiration. Inspiratory expiratory change over the cycle variable ends inspiration when a preset target is reached. It is an independent variable cycle, the ventilator, and it may be volume cycled, pressure cycled, time cycled, or flow cycled. In volume cycled ventilation, the ventilator cycle to end the inspiration and begin inspiration when a predetermined volume is delivered to the patient, and the pressure developed is variable. I depend only on the volume. Once the volume is reached, the cycle is ended. The amount of pressure generated to deliver the precise tidal volume, اللي هو positive inspiratory pressure, varies according to compliance and resistance factors. A time cycled ventilator, time cycled ventilation, inspiration ends and expiration begins after a predetermined time interval is reached. Cycling may be controlled by setting rate or adjusting the IE ratio or percentage of inspiration time. The pressure and inspiratory flow and the tidal volume may all be variable. Breath to breath, the tidal volume is determined by flow rate multiplied by inspiratory time. The flow rate must be adjusted to achieve the desired tidal volume. In pressure cycled ventilator, inspiration ends and expiration begins when a predetermined maximum airway pressure limit is reached. The volume delivered and the flow rate and the inspiratory time all vary breath to breath. In flow cycled ventilation, inspiration ends and expiration begins when the flow rate decays to a predetermined of its peak value. This critical flow rate is which cycling occurs is called the terminal flow rate. The volume in the lung and the inspiratory time vary from breath to breath. Expiration, the variable controlled during expiration is the baseline variable. Baseline variable is the parameter controlled during expiration, which is PEEP. Mechanical ventilation breath types. You have to read it. Mode of ventilation, either controlled mode or assisted controlled mode or synchronized intermittent mandatory ventilation or pressure support ventilation. Thank you, my dear. I hope my slide help you in studying.